Welcome to the CaringKind annual meeting. My name is John Latham, and I have the privilege to serve as the co-chair for the CaringKind here in New York, along with Steve Casper. So this evening is designed to address issues of concern to the greater Alzheimer's community. We have another great turnout, as we have for every year, which really demonstrates how important this topic is to everyone. So we have a distinguished panel of speakers who you will meet soon, and a wide-ranging audience with us today, including representatives from the Veterans Administration, the NFL Players Association, the Actors Fund, members of the aging and long-term community, and most importantly, the caregivers. I'd like to extend a special thank you to tonight's sponsors, my fellow board member, Bill Brachfeld, and Jane, his wife, for making this program possible. They have been very generous supporters for the past 5 years now, and we really thank them for that. Last but not least, I'd like to introduce Llewellyn Barkin, who serves as our president and CEO of CaringKind. Under her fantastic leadership, and I do mean fantastic leadership, we successfully launched CaringKind at the end of last year. Llewellyn will share some more exciting details about that with you shortly. Thank you, Llewellyn, for everything you've done around our mission for care and support to New Yorkers. You are the heart of Alzheimer's caregiving. Llewellyn Barkin.
Thank you, John, and welcome everyone to the 29th annual research meeting and the first with our new name, CaringKind. On behalf of our staff and our clients, I thank the CaringKind board members who are with us here tonight. You continue to be our wise and generous advisors, and I would ask you all to stand and be recognized. And I know you're not shy. So the board members in the room would stand and wave at everybody. We can all take an opportunity to thank you for your hard work. Thank you. Of course, like John, we have particular thanks for our board member, Bill Brachfeld, and his wife, Jane, for routinely and kindly underwriting tonight's event. And the evening would not be possible without the support of our wonderful volunteers, and as always, our outstanding staff, particularly our Senior Vice President of Development, Carol Byrne, and our Development Manager, Chrissy Vescendiz. As the issues of healthcare, Alzheimer's disease, and caregiving are more and more often the subject of public interest and debate, there has never been a more important moment to confront the issue of traumatic brain injury and chronic traumatic encephalopathy, what we call CTE. We live at a time when, notwithstanding the growing body of evidence about the dangers of head injury, contact sports are both prevalent and popular, and some of the most precarious are also the most profitable. At CaringKind, as experts in dementia caregiving, we know all too well the risks of head injury from any cause. We also know that there are research scientists, two of whom are with us tonight, who are working to better understand the science behind the brain and the impact of brain injury. I always like to tell a story, so I'll tell you a little story about a few years ago when I attended a lecture at Rockefeller University where their new president at the time, Dr. Mark Tessier-Levine, was speaking about his work in neuroscience. Dr. Levine is actually a wonderful speaker, and although some of the information was dense and somewhat complex, the audience was very engaged. And following the presentation, as is our practice here, the audience was asked to submit some questions. And they were sort of expected, opportunities to clarify Dr. Levine's presentation. Then one woman stood up and she asked an unexpected question. Dr. Levine, she asked, what can I do to live longer? Well, Dr. Levine paused, and then he decided to share the secrets that he and his colleagues had been working on for decades. And I can feel you all sort of moving toward me, right? I have, he said, 4 things that are guaranteed to help you live longer. And this was unexpected, and the audience leaned forward a little bit farther. First, he said, don't smoke. Second, he said, wear your seatbelt. Third, he said, wear sunscreen. And finally, he said, don't fall down. And everyone in the room is keeping score. And I'm pleased to report that as a woman of a certain age, the first 3 were things I'd been doing for years, and the last was certainly something I was aware of. But it wasn't until I got home that night that I realized I had only considered half the story, because there's a big difference between falling and those things that put someone at risk for repetitive head injury. Football, soccer, lacrosse, gymnastics, horseback riding, and many other sports carry with them the risk of traumatic brain injury that has lifetime implications. And as the mother of a high school and college football player and the grandmother of high school and college athletes, I am concerned about their safety. We also know that the military has been gathering important data on the prevalence of traumatic brain injury and CTE in the armed forces. As the daughter of a veteran of World War II, I'm concerned that my father's dementia may have been affected by his service in battle. And as those of us in the aging field know, falling is one of the most common causes of injury to the aging population, creating extraordinary challenges for families trying to take care of an older adult. And as the population ages, this will be a problem for many of us here tonight and for our families. I'm proud to say that CaringKind's programs and services can be of invaluable assistance to those affected by a dementia diagnosis, regardless of the cause. Our 24-hour helpline, our social work counseling, our Medical Alert Wanderers safety program, our early stage programs, and our training and education programs can dramatically improve the life of the caregiver and, by extension, the life of the person with dementia. Our outstanding staff of over 75 professionals is a strong community of caring people with deep local roots in the city we call home. At CaringKind, we've created a world where the stigma of an Alzheimer's or dementia diagnosis no longer forces families to retreat, but helps them to reach out and ask for help. And all of our services remain free of charge. So for this, I thank those of you who are here tonight who have supported us, and I thank those of you who will support us in the future. Your support has never been more appreciated or more important. Now, to tonight's program. Please note that following the presentations, our panel will respond to as many questions as we have time for, and feel free to ask them how you can live longer. And they will also be available during the reception following the program. And before we start, please remember, as I just did, to turn off your cell phone. It's now my pleasure to introduce tonight's moderator, Dr. Max Gomez, CBS 2 medical reporter, a nine-time Emmy Award-winning journalist. In his more than 35 years of reporting on medical news, Dr. Gomez has been instrumental in elucidating medical issues of importance to each of us, as well as to better understanding breakthroughs in many medical disciplines, including dementia. CaringKind was thrilled to honor Max in 2011 with our Public Awareness Award for courageously sharing the story of his father's struggle with Alzheimer's disease. Dr. Gomez is the co-author of the Prostate Health Program and the Healing Cell, How the Greatest Revolution in Medical History is Changing Your Life. Please join me in welcoming Dr. Max Gomez.
Thank you, Llewellyn, and it is my honor and pleasure to be here again. I've kind of lost track of how many years we've been doing this together, but it is an honor to be here. And I know that many of you out in the audience, as I have been impacted by Alzheimer's disease as I watched my father deteriorate and eventually pass away with the disease a few years ago. So I am not just, as they say, I'm not just a client, I'm not just the president of the Hair Club for Men, I'm actually a client as well. Well, no, not for hair anyway. You know, this is mine, this is all my own, I promise. Anyway, let's start with my moderator hat on. This is an interesting evening because I think this is where we're going to have an intersection between something that we've been talking about for an awful long time, Alzheimer's disease here, and something that's been in the news more recently, traumatic brain injury, and sort of the intersection of the two. And these are some of the questions, how these two intersect and whether or not some of this might lead to the other is what we're going to get to, hopefully, with our panelists tonight. So we'll take a closer look at TBI, traumatic brain injuries, their relation to memory loss, cognition, and dementia. We'll cover such questions as what exactly is TBI, what are the long-term impacts of repetitive head impacts, like those in contact sports, and what do we know about prevention? Is there such a thing, other than not falling down, right? Okay. We'll spend the next hour getting to the heart of the topic, And we'll begin by introducing our panelists. I'll do a little question and answer period. We'll also be asking the panelists questions that you submit on the index cards I believe you got when you came in. Based on previous experience, I know there are many of you who are frustrated physicians based on your handwriting. So please try to write it clearly so that I can actually read the questions to our panelists. We'll have ushers come around in about half an hour or so to collect those cards, and we'll try to get to as many of those questions as possible. And then, of course, we'll conclude, as we often do, with brief remarks by Jed Levine, the Executive Vice President, Director of Programs and Services at CaringKind. And of course, after the event, you have a chance to meet our panelists and share in some light refreshments out in the lobby. So without further ado, let me introduce our panelists, and then we'll get started. To my immediate left, Dr. Robert Stern, Professor of Neurology, Neurosurgery, and Anatomy and Neurobiology at Boston University School of Medicine, where he's also the Director of the Clinical Core of the BU Alzheimer's Disease and Chronic Traumatic Encephalopathy Center, henceforth known as CTE, because I don't know if I can pronounce it correctly more than a couple of times. Dr. Stern's research focuses on the long-term effects of repetitive head impacts in athletes, including the neurodegenerative disease, again, chronic traumatic encephalopathy, CTE. He's a lead investigator of a $16 million NIH grant for a multi-center study to develop methods of diagnosing CTE during life and examining potential risk factors for the disease. His other major area of research includes the assessment and treatment of Alzheimer's disease and the cognitive effects of chemotherapy in the elderly. Dr. Stern serves on the Mackey-White Health and Safety Committee of the NFL Players Association and was recently appointed to the Medical Scientific Committee for the NCAA Student-Athlete Concussion Injury Litigation. Dr. Stern has testified before the U.S. Senate Special Committee on Aging. He appears frequently in national and international print and broadcast media for his work on CTE and Alzheimer's disease, including 60 Minutes, ABC World News Tonight, CBS Evening News, NBC Nightly News. You get more airtime than I do. Good Morning America, Nightline, and several NPR shows. We're going to make you join after in a minute here, I think. He also appears in the feature-length documentaries League of Denial, Head Games, and I Remember Better When I Paint. He was recently listed by USA Today as number 7 on their list of the NFL's 100 most important people. To his left, Dr. Sam Gandy, who is a Mount Sinai Endowed Chair of Alzheimer's Disease Research and Professor of Neurology and Psychiatry. He is also the Director of the Center for Cognitive Health and NFL Neurological Care. Dr. Gandy is an international expert in the metabolism of the sticky substance called amyloid that clogs the brain in patients with Alzheimer's. Dr. Gandy has received continuous NIH funding for his research on amyloid metabolism since 1986, and in 1989, Dr. Gandy and his team discovered the first drugs that could lower formation of amyloid. Now here's the really exciting part. More recently, he was featured with other prominent research scientists in GQ's 2009 list of rock stars of science. I know, I'd wear that as a badge of honor if I were you. Dr. Gandy has also appeared on numerous television programs, including the Jim Lehrer NewsHour, the CBS Early Show, NBC Nightly News, ABC News on Call, and has spoken before Congress on several occasions. So let's get started, and to give us kind of a brief overview, I'm going to ask each of you to give us, maybe 3, 4, 5 minutes, a little overview of your research interests, where you're coming from, and how you intersect or interact with this area of Alzheimer's disease and traumatic brain injury. And Bob, why don't we start with you?
Thank you, Max. First of all, it's really an honor to be here. It's incredibly an honor to be sitting next to Sam Gandy and sharing this panel with him. But I also want to thank you for moderating this third and final debate.
You couldn't pay me enough to do that.
I was going to stand behind you, and we'll see how it turns out. I still might do that.
You're pretty good.
I'm going to start by just saying something a little controversial. I really don't care that much about traumatic brain injury and concussions when it comes to this neurodegenerative disease called chronic traumatic encephalopathy. I'll describe probably why I say that
You're
very
going to have to.
controversial statement a little bit later, but let me just kind of describe how I got started in this field. And that I won't get into the whole story, but around 8 or 9 years ago, I was giving a talk like this, and I said what was commonly said at the time, which was a risk factor for Alzheimer's disease was having a prior traumatic brain injury. That's what we all believed then. The next day, I get a call from the folks who sponsored it saying there was someone who wanted to meet me because his roommate was in the audience and this guy had a special interest. His name was Chris Nowinski. And any of you who've been following this story, you know that Chris is a former Harvard football player and WWE professional wrestler, and he really is a key person in this whole story that's been unleashed over the last many years. And he met in my office, and I heard about this whole issue of trying to understand what happens after people get their heads hit a bunch. And in those days, we thought it was having a lot of concussions, having traumatic brain injury. And the idea was that it led to what used to be referred to as punch drunk or dementia pugilistica, when we thought it only happened in boxers. And so this relationship between traumatic brain injury and neurodegenerative disease, and perhaps later dementia, is something that's been looked at in multiple ways for a long time, but it's only in the last 8 years or so that we've started to really uncover and understand this very complex relationship. So let me just explain what I view as where we are right now. And that is that this disease, CTE, is a similar disease to Alzheimer's disease in that it is a tauopathy. It has this central element of it, an accumulation of an abnormal form of the tau protein, similar to Alzheimer's disease, but in different parts of the brain. But similar to Alzheimer's disease, it is a progressive disease that eventually can lead to dementia. And perhaps early on, it can also result in changes in mood and behavior, impulse control, depression, rage, and then memory and cognitive impairment. But different from Alzheimer's disease is that at this point, we're pretty confident that we know that it has a specific risk factor, or a factor that is necessary for the development of the disease. And that necessary variable is a history of getting your head hit over and over again. It's not a sufficient variable because obviously not everyone who's gotten their head hit gets this brain disease. But from our research so far, it really does seem that there is a direct relationship between the overall cumulative exposure to hits to the head and the development of this neurodegenerative disease. The thing is that the hype around this disease over the last several years has made the public and even people within science think that we know a lot more than we do. And the hype is, it's everywhere. I mean, you can't even pronounce the word encephalopathy, and everyone's talking about it. It's been on like every major television drama. Everyone thinks they know something about it, and it's led to this incredible fear of a kid having a concussion, or everyone's going to get this disease, and we have to do something about it. And this also has led to this confusion between traumatic brain injury and CTE, one being the injury, one being a degenerative brain disease. And yet the reality is, even though we think we know so much based on all the media, we really know very little. Thanks to people like Dr. Gandy and others, we're starting to get there. I used to say we're in the infancy of our knowledge of this disease, but I think we'd say more safely we're in the toddlerhood.
Okay.
So much more to find out. And it all now comes down to being able to diagnose this disease during life, to follow the incredible work that's been happening in Alzheimer's disease over the last decade or so in our ability to diagnose Alzheimer's during life. We can now exploit those kinds of techniques and approaches to be able to try to diagnose CTE during life, because it's only then that we'll be able to answer the very important questions that really do remain.
Very good. We're going to ask you to defend some of that here in just a minute.
No, actually, I've got to leave.
Gotta go.
Thank you.
Now, the doors are locked. Sam, why don't you tell us a little bit about your research, please?
It's that media conspiracy.
Oh, I knew eventually it was going to come back to the media.
Thanks, Max and Llewellyn and the CaringKind group for inviting me here to address you tonight. Like Bob, my career has been sort of a hybrid of studying Alzheimer's disease and the effects of brain injury. I spent most of my time in the last 30 years with modeling the pathology, the pathological changes of Alzheimer's disease in animals, in little laboratory mice, because we need those structures and we need the behavior to try and develop medications. And as you probably are aware, we've been able to cure Alzheimer's in mice very easily, not so in humans. And the challenge with Alzheimer's disease, we know what the pathology is. We have medications that will touch or adjust, reduce the pathology, but we haven't been able to get the drugs in early enough, soon enough. What's soon enough? Soon enough may be around 45 or 50. And at this point, we're starting at age 65, and I think we're still going to be there too late. One of the attractive things about studying traumatic brain injury and its relationship to brain degeneration is that we know when the insult happens, so that if we can develop ways to target the pathology, we can begin as soon as the concussion, as soon as the head injury happens, or very soon thereafter. So that makes that an attractive place to move. In our laboratory, we've developed a number of medications aimed at reducing the buildup of this material called amyloid. But now we've turned to a different medication, a couple of different medications. One that stimulates birth of new nerve cells, and we've been able to show that in a rat model of exposure to improvised explosive devices to blast injury, that stimulating the birth of new nerve cells will help that animal recover and recover its ability to learn and not be anxious, to sort of not have PTSD, which is sort of the phenotype or the clinical picture that we get with this animal. But also what we've done, probably more relevant to CTE, has to do with diagnosis. I've been involved sort of off and on with brain trauma and brain imaging over these 30 years that I've been doing these animal experiments. And the first brain imaging work we did was when I was in training, and we were the first to discover that you could use MRI to see brain contusions that were invisible on CT. No one had ever seen some of these contusions before. We're able to diagnose and visualize contusions that heretofore weren't visible. As the genetics of Alzheimer's disease and how they may interact with brain injury began to be involved, we had the opportunity to study boxers. Bob mentioned that CTE was initially thought of as dementia pugilistica, was thought to be specific to boxers. Was only really in 2006 when a neuropathologist named Bennett Amalu, probably may know about the movie Concussion from last holiday season, recognized it in a football player, Mike Webster, from the Pittsburgh Steelers, who had become demented to the point that he was living out of his car, destitute, and died there. And it was when his brain was examined by Dr. Amalu, he was surprised to find the pathology that looked just like what had been described for boxers. And that's when the name was sort of broadened. CTE had been used many years ago when the attachment to boxers became clear. There was called dementia pugilistica for many years, but then CTE became a more useful term now that it's been described in a number of collision sports and in soldiers, battlefield veterans exposed to improvised explosive devices. Most recently, working on CTE in humans, we've been focusing on ways to visualize the pathology during life. As with Alzheimer's, for many years, it was impossible to, and still is impossible to confirm the diagnosis of CTE during life. If I could have the image that I was going to ask for. Can I get that up there? So we've been using a particular type of brain scan that will reveal, we believe, the pathology of CTE in living retired athletes, and soldiers. So what you see here are these brain scans. On the left is the scan from a normal person, also around 40. And on the right is the brain of a former NFL player, 39 years old, suffered 22 documented concussions, and was recognized by one of Bob's colleagues, Bob Cantu, as having CTE 5 years ago. But once we started this brain imaging protocol, testing these brain images, he came to be evaluated by us as well. So his clinical symptoms, and this is one thing, we lump these CTE and Alzheimer's together as dementias, and CTE certainly does eventually dement, but often presents as a psychiatric illness, with sharing many of the features of post-traumatic stress disorder. And this particular retired player has problems with rage control, with irritability and controlling his anger. He's not really that cognitively impaired. He continues to run a business and function quite well. But what you see on the right is his brain, and a scan of his brain, and the orange areas in the middle that you don't see on the right, and that sort of, especially near the surface, near the sort of the outer rim of that brain. We believe that's the pathology of CTE. This is using a type of imaging chemical that is specific for tauopathy that Bob mentioned, or neurofibrillary tangles, the characteristic features of CTE. So we've seen this in a number of retired NFL players with clinical CTE. We reported this particular patient because the pattern of where the pathology is located is very characteristic. One of Bob's colleagues, Ann McKee, and a group of neuropathologists recently described, or sort of got together to establish how to diagnose CTE even in autopsy. And finding the accumulation of this tau material, these tangles, around the wrinkles of the surface of the brain occurred in CTE and nowhere else. And that's what we saw with this particular player. You can see the orange spots there are located at near the bottoms of the wrinkles. And that's what we were drawn to when we reported this, and this appeared in the Journal of Translational Psychiatry last month. Now, being able to see this during life, We were approached by a biotech company who have developed a drug that will touch and cure this tau buildup, these tangle buildup in mice. And so we're about to undertake a clinical trial with a medication that we hope will be effective in reducing the accumulation of this material and will relieve or at least arrest the progression of the disease.
Good.
Max,
So,
I think you had 30 seconds more.
Clearly, neither one of you know what 5 minutes means. Both of you got a little bit ahead of me, so let's take a couple of steps back here, and let's start out with, Sam, tell me, what's the definition of a concussion? Do we have a really good definition for a concussion, and what's the difference between a severe one and a so-called mild concussion? Is there such a thing?
On me? Mm-hmm. So there are approximately 40 different published definitions of concussion in the medical literature, and it keeps changing. The most kind of general way to describe the current view of what a concussion is when the head or body gets struck and the resulting impact makes the brain move inside that hard skull. And it results in a variety of changes within the brain cells that then results in a variety of symptoms. Symptoms can be anything from seeing stars, to having a headache, being nauseated, having poor balance, feeling in a fog, having poor memory, emotional changes, sleep disturbance, this wide array of changes. So it's basically, you get yourself hit and you have symptoms. That's a simplistic way of doing it. What's going on inside the brain is an amazing complex set of changes that are happening at the molecular, metabolic, biochemical type of stage. That's a concussion. But the important thing about a concussion is that by definition, you would not see any injury to the brain with typical neuroimaging techniques, the ones that are used clinically. And by definition, the symptoms will eventually go away.
Resolve.
So that's a concussion. A concussion is also referred to as a mild traumatic brain injury, or MTBI. So people have to think that, it's just not getting this kind of minor little thing and it'll go away. It is a brain injury, so it has to be taken seriously. The difference between a concussion or a mild traumatic brain injury and the types of injuries that would be referred to as moderate to severe brain injuries have to do with what one sees on a CAT scan or an MRI, that there's actual injury, the extent of the symptoms at the time of the impact, the time of the injury, with loss of consciousness, extended loss of consciousness. You don't need loss of consciousnous to have a diagnosis of a concussion, but you do for a moderate to severe traumatic brain injury.
But if you lose consciousness, that's automatic. I mean, that is a concussion.
Or if there's an actual injury you see and it's actually a bigger thing, then it's more. But yeah, if you lose consciousness, that's a concussion. 90% of concussions don't involve the loss of consciousness. So there is this kind of spectrum, this continuum of severity of injury, from the mild type of, yes, you're hit, you have symptoms, to the incredibly impactful brain injury that leaves someone truly impaired, perhaps for life.
So Sam, is it fair to say then what we would normally refer to as a traumatic brain injury is on that more serious end of the spectrum? From a concussion, by the time we call it a TBI, you're really much further along?
We usually use adjectives mild, moderate, and severe TBI to sort of separate the levels of severity. And mild TBI and concussion are fairly interchangeable. Moderate is usually if there's amnesia or loss of consciousness. And severe, obviously, is if there's coma, basically, an extended period of unconsciousness. Now, the clinical things that we see, people, we focus on the brain because we're all sort of, believe that's where all the action is, but there are other things in the skull as well, and they can give rise to symptoms. And just to sort of finish the picture on the clinical side, because there are blood vessels, there's the covering of the brain, and there's the machinery that's involved in balance. And those structures, blood vessels, the meninges, the covers, and the inner ear are also vulnerable to being disrupted by shaking, and they can give rise to symptoms. So whenever we see people with post-concussive syndrome, some unresolved symptoms of a concussion, some of their symptoms are due to what's happened to their brain, but some of their symptoms are due to what's happened to the covering of the brain, or the blood vessels, or their inner ear.
And often, just to add to that, it's also what's happening in their cervical spine too, where that whiplash effect, or often that can lead to problems with headache, pain, and just feeling just strange. And oftentimes those are neglected and not treated appropriately, and the person continues to have those symptoms. And that's one of the best things that can be treated. And so it is this complex array of symptoms that are from the brain injury itself as well as those other things.
So let me ask you this, because we all know people who have had what seems to be a relatively mild bump to the head or fallen. Lou Ellen, you should avoid that, by the way, falling. Take a bump on the head and have pretty significant symptoms, and others who had a couple of concussions, play contact sports, and seem to be doing just fine. What's the difference? Do genetics play a role in here, or do some people are just simply more susceptible, not unlike, I guess, smokers? Some smokers are much more susceptible to the effects of smoke and tar and nicotine?
Well, if we had the answer to that, we wouldn't be sitting here right now.
I think I'd give you the easy.
Genetics always play some role in terms of predisposition. The question is how much of a role. It's also, these are complex types of injuries, and it really depends on the mechanics of the injury, the extent of the brain trauma itself. Also, what the person comes to that trauma with. If they've had a previous head injury or concussion, if they've had a previous psychiatric history, if they've had a previous history of ADHD, if they have many different possible things can lead to perhaps a lowered threshold or perhaps an increased threshold on how someone responds to that bump on the head.
So the genes can determine also what pathology builds up. There is one gene that's especially prone to cause the buildup of amyloid pathology, but also the age of the person at the time of the fall. I can give you from personal experience. My mother, now 91, lived independently until 90, and she fell and struck the front of her head, and went from being a little forgetful to moderately demented, and just lost her independence and requiring nursing home admission. So, at 90, she went from a little forgetful to demented with sometimes even psychosis due to a single head injury.
Let's get to what I think a lot of people want to get to, some sort of a little bit of a bottom line if we can. CTE is not the same as Alzheimer's, right? CTE symptoms can look very much like Alzheimer's, the same sorts of dementia. Mild cognitive impairment, would that be a part of CTE?
Well, one has to think that mild cognitive impairment is when there are cognitive difficulties that aren't getting in the way of daily functioning. Mm-hmm. That can happen in CTE too, along the progression of the disease. What's interesting with CTE and what makes it perhaps a complex thing to study is that, like Sam was saying, some of the early symptoms, for example, in the case that had the PET scan, are behaviorally based and mood-based and not necessarily cognitive. What we did in my lab is we looked at all the people whose brains were diagnosed neuropathologically, post-mortem with CTE, and looked at their histories before they had passed to see what it was like. And we saw that there were two different subgroups, it seemed. One group that started with these mood and behavioral changes earlier in life, maybe one's 30s, 40s, and another subgroup who started with the more cognitive, memory, executive function type difficulties later in life, 60s, 70s. Some people have both, but the question is, what's going on early on in some of these people who have these changes in mood and rage and impulse control? Because it's not just CT that results in those things. Right. There's a lot of people in their 30s and 40s who can have, depression for all kinds of reasons, can have rage, can have problems with impulse control. And so trying to figure out what that direct relationship is between the CTE pathology and those presenting problems is hard. But yeah, it is similar to Alzheimer's that it's going to start earlier in life and it's going to get worse. And what the specific symptoms are have to do probably with what parts of the brain are directly involved at that time.
From the trauma, perhaps, in terms of what parts of the brain have been traumatized?
That's a good question. I guess I would say that that's not necessarily it. Because as I was trying to say earlier, CT isn't the same as the brain injury. And that it is a neurodegenerative disease that seems to get set in motion earlier in life at the time of the repetitive trauma, the repetitive hits. Not necessarily at the place where the injury was, or injuries were, because they could be multiple. But once that cascade of events gets set in motion, it eventually leads to disruption of the functioning of the neurons and then the destruction of the brain cells and the atrophy. And so it's not necessarily, I get hit here, I'm going to have problems there. It's, I get hit over and over again over a number of years, and that seems to set in motion this progressive change in the brain.
Sam, I have a question for you, but one quick second. Should we go, hang on, I promise, I'll get it. Should we go ahead and start collecting our questions? I think if you'll pass your cards out to the aisles, we'll have some folks pick that up so that we can make sure that we're getting those taken in. Sam, go ahead, please.
I just want to add that there, to some extent, how these people appear clinically differs by the sport. Boxers with CTE tend to be more in the sort of withdrawn, apathetic, demented category, like as Bob was discussing, while football players, hockey players tend to have the psychiatric piece and violence, suicide and homicide.
Although I can add to it, first, another part is that the boxers, for the most part, have very commonly movement disorder changes. They have what can look like Parkinson's disease or Parkinsonism, tremor.
Parkinsonian.
That's right, exactly. But many of the other types of activities that can lead to CTE don't necessarily have that. But I just want to add that this is something really important that we've been seeing now over and over again is in football players who are seen after they die. And we're not just talking about professional, we're talking about college players who look, when we hear about their history, prior to knowing what their neuropathology shows, what the slides show, you hear the story. And so often we hear this story of the 60-year-old who starts having memory problems with no difficulties prior to that. And then it starts to progress, and then they have other cognitive difficulties. And for someone who is involved with diagnosing Alzheimer's disease on a daily basis, I hear the story of an Alzheimer's-like history. And then we find out what the neuropathology shows, and there's not a stitch of Alzheimer's disease pathology, it's all CTE. And we see this over and over again. So there's a lot of kind of mixture there, not necessarily just based on the sport, but just on something that we just don't know yet. Why do some people develop it one way and another person another way?
So Sam, we know that Alzheimer's tends to affect a certain area of the brain, the hippocampus and the temporal lobe, right? Are the areas that seem to be affected in CTE, is that consistent? Are they consistently the same areas being affected? And is there a correlation between the areas that are affected in the scan and the behavioral or cognitive effects that you see, the clinical effects that you see with CTE?
The two diseases, Alzheimer's and CTE, can be distinguished under the microscope by the distribution. This particular signature of the tangles, the tau, building up under the wrinkles of the brain doesn't occur in Alzheimer's disease. That occurs only in CTE. The presence of amyloid, this sticky material that builds up on the outside of cells, is a consistent feature of Alzheimer's, only present in about half of patients with autopsy patients with CTE, and usually correlates with their having a particular gene that we know increases amyloid buildup. So they can be distinguished pathologically, and they can coexist. There have been people found to have both Alzheimer's and CTE at the same time.
As well as other diseases like Parkinson's disease or PSP or CBD, all these other types of brain diseases. Just because they have one doesn't mean
You can't have more.
luck doesn't prevent you from having another.
But do the CTE changes that you see, for example, if you get them frontal or prefrontal cortex, do they seem to correlate then with what we typically think of the functions that reside there, the executive decision-making functions, or not?
So we've done the same type of scan that Sam's group has been doing with around 30 former NFL players and trying to see if that same kind of signature and other types of finding on the PET scan is related to the clinical picture. And we're not finding anything consistent at this point yet, because I think we may be too early in the course of the disease. I think as we see more people and as we have a better understanding of what the pathways are between these types of little kind of areas of illumination and the rest of the brain, we'll probably see that more clearly.
Sam, is it fair to say that, well, clearly, not everybody who gets hit on the head even more than a few times develops CTE?
Sure.
Right?
Not even every boxer develops it. Some boxers are fine.
But the more you get hit on the head, the likelier it is that you're going to develop CTE. Is that a correlation?
I think you have to have the right vulnerability as well. I think it's a combination of both the genetics of how resilient your brain is, as well as how many hits you get and where they are.
Now,
And age as well plays a role.
We've been trying to model how many hits someone gets over the course of their life based on studies of like accelerometers, these gizmos put in helmets that measure the amount of force that each person gets. So we're trying to kind of model how many hits someone gets and see if that is related to their clinical functioning or other changes that we can detect during life later on. And we're finding a very direct relationship, a dose-response relationship. But between the number of overall hits
and the kind of
later in life problems, both cognitively as well as alterations in certain special tests, blood tests that we're doing.
which may be CTE and Alzheimer's?
Or maybe something unrelated. We don't know yet because we don't have that definite way of diagnosing CT during life. But what you're saying is critical, that it's not just the number of hits. It's also something else, likely genetics. And so what we're trying to do is put both together in our models of a whole variety of genetic assessments and measures of how many hits.
We make this sound like it's an older person's disease, but that's not necessarily true. You know better than I, the youngest person with CTE in the teens?
Yes.
Wow. So,
Sadly.
but the $64,000 question here is, will repeated blows to the head lead to Alzheimer's? Or does that put you at greater risk for Alzheimer's?
I'll go out on a limb and say no. I don't think we have any evidence that suggests that. And I think that perhaps a lot of the previous findings that did suggest that there was a relationship between having a traumatic brain injury and Alzheimer's later may, in some cases, have been perhaps tainted by that person's history of having exposure to repetitive hits. Example, there was a study from the Mayo Clinic, from their brain bank, looking at a whole lot of people who had died with a variety of neurodegenerative diseases, and then they went back and they looked at the pathological picture of CTE to see how many people would have that. And what they found was, to make a long story short, in that kind of community-based brain bank, 1/3 of men who played contact sports, amateur contact sports, most of them were football, high school, college football, 1/3 of them had evidence of CTE pathology after they died. They might have been diagnosed with other things when they were alive, clinically. But I think part of what the picture is that CTE is actually playing a greater role than we previously had thought.
And we probably tend to call, I think at least lay people do, almost any dementia, we just call it Alzheimer's.
Well, we don't call it, we just call it dementia.
Yeah, and I mean, but it just sort of muddies the water. But Sam, do you agree with Bob, is that repeated blows to the head may not put you at greater risk for Alzheimer's?
Well, it puts you at risk for CTE, for it's another dementia. I think the head injury, Alzheimer's connection is genetic. I mean, we know, Gene, that when in response to head injury will cause amyloid to build up, and that can then confound the picture. CTE is primarily a tangle disease, a tau disease, while Alzheimer's requires both plaques, amyloid, and tangles. And the
Tangles inside the cells and the plaques outside the
That's
cells.
right.
Okay.
And though the CTE patients can have amyloid, we know that still is linked to this gene that promotes buildup of amyloid. So I think that's the explanation for how they get confused, is the genetic component. If you have a particular genetic predisposition and you have certain sorts of head injury, you may get one or the other, depending on what your genetic susceptibility is.
Is there a way to prevent or at least minimize the impact, no pun intended, of repeated blows to the head in sports? And by the way, you know, this is not just, we think of football as being it, but we see this in, as you mentioned, all sorts of sports. And I've done a number of stories saying I think the number one cause for concussions in teenage girls is cheerleading injuries. So it's not just contact sports, but is there a way to we're not going to put helmets on cheerleaders, obviously, but in these contact sports like lacrosse and football and so forth, is there a way to minimize it?
Let me throw something out. That will focus it more on football and indeed boxing. Mm-hmm. And it goes back to what I was saying before, that the concussions are not necessarily the issue. Think about the history of humankind. I'm going to play anthropologist here. 200,000 years, that's how long humans have been around, right? When I talk to my anthropologist and sports anthropology friends, I ask them, was there ever any activity that human beings have done that involved repetitive hits to the head? The answer was no. Not until the 1950s. In the 1950s is when, in boxing, big padded gloves were put on, not to prevent brain trauma, but to prevent breaking your hand when you're hitting. But it allowed for more and more repetitive hits. But perhaps more importantly, at least in our country, was the development of the hard plastic helmet and the face mask, that together allowed football players at all different levels, at that time high school, college, pro, to hit each other repeatedly. Prior to that, no. The helmet was created in order to prevent the skull fracture, so someone wouldn't die, but it also allowed people to start hitting their heads. In the history of humankind, that kind of repeated hits didn't really start until the 1950s. And then add one extra step, and this has to go to kind of prevention. It wasn't until the late 1960s and early 1970s that Pop Warner football became a national deal. In other words, it wasn't until late 60s and early 70s that we started having our children go out on a field and hit their heads with these hard plastic helmets over and over and over again. We have some research, I won't go into the details, that has shown that if you start hitting your head before age 12 repeatedly, compared to starting at 12 or older, it seems to increase the risk for later life problems. So we have this issue of our human history not knowing where we're going. Because the people who started playing American tackle football as children are only in their 50s right now. This is a disease of aging in terms of getting progressively worse, seeing it as someone gets older. And so I'm not sure where we're going with it, but I think when it comes to the prevention question, it's not the number of concussions, it's not putting helmets on cheerleaders, it's thinking about what activities we do as humans that result in this repetitive 1,000, 1,500 times per year hits to the head.
So Sam, speaking of helmets, is there a difference between guys, let's talk about that, play tackle football, wearing helmets, and rugby players, for example? Another pretty rough sport, but they're not wearing helmets. Are they getting as many blows to the head or concussions?
They aren't getting as many hits. They aren't certainly not as hit as frequently or as hard as the football players.
We've seen CT neuropathologically in two, I think, rugby players at this point, who never played anything else, but they had awful CTE and died after several years of progressive dementia. We don't know, but I think there aren't the number of hits that you see in football.
Can we now diagnose both AD, Alzheimer's disease, and TBI before a post-mortem?
TBI or CTE?
Okay, all three.
What we can do is see some of the pathology. We still have to have the right clinical syndrome to put that together. For example, in Alzheimer's disease, you can visualize amyloid with brain scans, but that can occur up to 30 years before any symptoms occur. So it doesn't necessarily guarantee that there's Alzheimer's is coming or is already there. So it's only supports the diagnosis that you find the pathology in the particular clinical situation. With TBI, what we can see with MRI and to some extent with CT is whether the brain is swollen or contused or bleeding. All of those things we can see and are related to TBI. With CTE, we're just beginning to do these brain scans and don't yet have anyone who's had a brain scan during life and then gone on to have an autopsy so that we can match the patterns. And that's what's going to be required to validate these brain scans.
So the goal of that research study that was mentioned earlier, this big multi-center study that was funded by NIH, as well as a previous NIH-funded study of mine, is to develop ways of diagnosing CT during life. It's not easy. We've been working for so many decades on Alzheimer's disease, but with work like Sam was showing, we're getting closer. But it's not just going to rely on even a clinical syndrome. You know, we published some provisional criteria for what it looks like during life, but you need biomarkers, you need objective tests like that. But we're also working on a variety of other things, in blood tests that are able to perhaps detect the abnormal tau from the brain in what's called an exosome, something that's like a little bubble that leaves the brain cell, crosses across the blood-brain barrier, and you can then isolate it in blood and measure the amount of tau that came from the brain. Those types of neat new things will be leading us to be able to screen for things earlier, so we can detect it years or decades before the symptoms.
And that's what it'll take to move from toddlerhood into adolescence in terms of the brain science, no?
Exactly.
Yeah, I mean, the state of the art is really to have the laboratory on the sidelines and to do blood tests, do brain scans with portable PET scanners, or do spinal taps. There have been studies done on boxers where they underwent spinal taps on the side of the boxing ring to do the studies. Basically, the laboratory is moved to the sports arena.
We've got this great experiment able to be done with CTE because we know that risk factor. And if we can measure things at the times of the injuries, the head impacts, then follow people for 50 years and examine them periodically, that would be fantastic. The problem is a 50-year study would obviously not be cost effective. I also am not going to wait 50 years before being able to diagnose this thing.
No, I think they're parallel tracks.
I'm not saying it's not. I'm just saying the idea is to do all that excellent work and be able to follow people to see where it ends up. But you have to do that work at the sideline as a starting point.
Yeah.
It's a necessary.
Well, as a parallel pursuit. I mean, one is to characterize the older people who are developing degeneration and CTE, intervene with anti-tau drugs or tau-lowering drugs, but to understand the concussion better so that we can, you asked if there's anything that you can do after a concussion to help. We just don't know. And we won't know until we understand the molecular biology of concussion.
And that's one of the questions that we got here. Are there any interventions once you either have diagnosed via PET scans or suspect via clinical symptomatology, concussion, CTE, TBI, or even Alzheimer's, any interventions that seem to or that we know can make a difference?
With TBI and even concussion, there's been decades of work trying to be able to figure out what can be done to help people after a brain injury. And sadly, to this day, there really has been no successful pharmacological treatment to improve TBI. When it comes to CTE, however, we're living in a really exciting time. I mean, if we were talking about Alzheimer's disease, it would be an incredibly exciting time to be able to talk about clinical trials moving forward with new agents that are able to intervene to slow the disease course and slow it even before the person has any symptoms. That's where we are with Alzheimer's. Same type of approach with CTE is really right around the corner. The compounds are being developed. If we can diagnose people pretty accurately, we can have them participate in clinical trials with these new compounds. We're getting there, and so there's a lot of hope.
Now, these tau-reducing drugs are being developed primarily for Alzheimer's, but they're also benefiting these other tangled diseases, including CTE.
So far, we've been mostly talking about these different types of brain injuries relative to sports. and/or motor vehicle accidents, I guess, is obviously another big area where you see traumatic brain injuries. What about domestic violence? Has there been much in the way of study there as far either domestic violence and/or some of our wounded warriors coming back?
There are isolated studies, but nothing nearly as systematic as what's been done in sports. Both the Department of Defense and the Veterans Administration are sponsoring investigations into trying to understand better in that population. Certainly, there seem to be some subjects who have had exposure to improvised explosive devices on the battlefield, who developed a syndrome that looks like CTE and PTSD. It has features of both sorts of syndromes. So I think that's going to emerge from that work. There's a bit done on domestic violence and on shaken babies, but not a lot. We actually were just approached to start a domestic violence project.
The interesting thing about the military is, as I think most people know, the signature injury of the last 20 years has been traumatic brain injury and everything that comes after it, but including suicide and including the really life-altering symptoms of PTSD. And there's so much crossover between the symptoms of persistent traumatic brain injury problems, PTSD, and CTE, that the Department of Defense has been putting a lot of effort into that. One of our studies using that PET scan is comparing Alzheimer's disease with former professional football players with those scans to be able to look at the tau buildup. And that's the Department of Defense trying to figure this out. But it's really important when we're talking about our military service members, what kind of prior history do they have before coming to the military? Even our elite military who went to the military academies, all of the military academies have boxing as a mandatory course. That's mandatory. It has been for decades, still is. What percentage of our military men played football or other collision sports prior to coming to the military? During early training, there's combatant training where people get used to being hit over the head or exposure to blasts as part of their training. And so prior to getting to the combat theater, there's a whole lot that the individual brings that makes it really difficult to understand, are they susceptible for CTE? Are they just having a single traumatic brain injury?
Muddies the data.
That's right.
And there are many fewer brains from vets have been examined so far. And even so, some of them have revealed some novel pathology, not just plaques and tangles, but what looks like shearing of the axons, the wiring in the brain, with fibrosis in the cortex, an entirely new lesion called an astrocyte or astroglial scar.
And is some of these, perhaps some of these, at least symptoms that we see, the result of the brain trying to heal itself in that way? Or do we know that?
Well, certainly there's shearing because, in the way the brain's organized, the bodies of the cells, of the nerve cells, are on the outside, and they're connected. The wiring sort of diagram is that the wires all go down together. And when the brain is shaken, that shears. The cell bodies at the top go in one direction, and the wiring goes in the other direction. And that's one of the main ways the nerve cells are injured.
It's an important thing that you raise of the brain trying to heal itself. We now know with most of these diseases, including Alzheimer's disease and CTE, a large part of what's going on in the disease process is inflammation. And the brain's attempt to try to heal itself, to get rid of bad things. But when that inflammation gets out of control, it can lead to a
counterproductive.
worsening of problems. And so when it comes to these injuries, whether it's a big traumatic brain injury or these repetitive hits, one of the first things the brain tries to do is to get rid of the bad stuff through an inflammatory response. But our sense is that with these repetitive hits, that good response is overtaken by the continued exposure to the hits, leading to the brain trying to take care of itself and it backfiring.
I have two questions left. I'm going to save the best one for last here, but one that I know that CaringKind wants to make sure that we get at, and that is, how do we graduate from toddlerhood to adolescence, teenage years, adulthood preferably, clinical trials? How important are those in advancing the science?
For me, clinical trials can only occur in large scale and an effective way if we know exactly who it is we're putting into the clinical trials. And so our ability to detect and diagnose CTE during life is the starting point, that very important piece that will allow us to get to adolescence, to then do the clinical trials that will hopefully not just treat and slow down the disease, but prevent the problems in the first place. Clinical trials, as with Alzheimer's disease, is the most important thing out there. But unlike Alzheimer's disease, where we're pretty good about diagnosing it, even detecting it early, we need to be able to get to that point with CTE.
Sam, does it have to do with, maybe clinical trials is not exactly the right term in the way we normally think of it, that you volunteer for something and there's an intervention, but at the very least, having people who have some of these diseases donate their brain or undergo some sort of testing that might actually advance the science that way?
Yeah, I think I would compare it to the way the Alzheimer's field moved forward. About 35 years ago, they formed Alzheimer's disease centers, about 30 to 40 around the country. And their job is to continually examine and characterize patients with Alzheimer's disease and examine their brains. And it was only that way that we were able to get people to sort of understand the clinical phenomenology and how that related to the pathology. And it was just sheer numbers, and that's really what we have to have.
Ready for the last one? I've interviewed and done a number of panels on which Harry Carson has served. And Harry, for those of you who are not New York Giants fans, NFL Hall of Fame, Super Bowl champion. The guy, I remember him showing me his massive hands and showing me his Super Bowl ring and his NFL Hall of Fame ring. And he said, I've got at the time he was, I think, 1 or 2 years old grandson. I'd never let him play football. Yeah. We hear that from a lot of people. I'm sure there are a lot of parents here who are asking that. And you mentioned Dr. Amalu from concussion. We know what he says. He says, stop all of it. Would you let your kids play football?
As can be imagined, Max, I get asked that question a lot.
Sure.
My oldest son played football. Multiple concussions, first in basketball, then in football. Fortunately, he wasn't big enough to play when he went to Yale, so he stopped, thank goodness. That was before I got into this stuff. And even a couple years ago, even a year ago, I would not answer in public that I don't think tackle football is a smart thing for kids. I now know perhaps enough as a parent, as a member of society, but also then as a scientist to say, we don't have all the answers yet. But we do some crazy things as parents to protect our kids from everything. Just imagine all those things we do. And we want to make sure that they have the best possible future. And yet, we drop them off at a playing field and say, go at it. Where on average, a youth football player hits their head around 400 times a season at a G-force greater than 15.
Wow.
Is that really in the best interest of our children's development? And so I guess now I will say, and I have already said, I don't think young kids should be playing tackle football.
Sam, where do you come down on this?
So at the level of policy, I'm not so much about advice as informing so that people can make judgments as to what the risk is. Is this one person with CTE every 10,000 players or every 100,000 players? Part of the goal of being able to diagnose it during life is to determine exactly what the risk is, how common it is, and what the risk is. So that I'm more about sort of making the informed consent process more precise so people can understand what risk they're putting their kids in. Is it 1 in 100, 1 in a million, rather than making a particular recommendation. Personally, no.
What I would say.
I want to respond as if I'm Hillary.
You're going to get us all in trouble. But my point, where I would take issue there is there really informed consent here? There might be with parents up on the Upper East Side who are not going to let their kids play tackle football. But is that really what you're seeing in, say, some disadvantaged neighborhoods when that's the way out?
You have to understand, this is the way out. And football, for so many people, is the way to avoid dying. That's straightforward, dying. In inner city African American communities, the numbers of young men who die before age 21 is so dreadful. Football is a way out. It's also, forget about that kind of big scary thing, it's part of our life, it's part of our culture. We love our football. And to try to say, nah, we're not going to do it anymore, that is a pretty big deal. And so we need to make sure that we understand the pros and cons, the benefits and risks. Kids need to have exercise. Kids need to benefit from being part of a team sport, from learning the leadership, the ability to be aggressive, all of the wonderful parts about being on a football field as a kid. But can we do that and also remove the brain from it, at least when they're young?
My sense has been, and others share this opinion, that for a long time the NFL was, if not part of the problem, not particularly helpful. Are they now part of the solution?
Well, so I think it's pretty well known that they tried to interfere with the support of Bob's research.
Did they? Oh, bummer.
And they help now. I mean, have
Can they help? Well, the NFL has gazillions of dollars.
I know.
And the NFL is doing a superb job in increasing awareness of concussion, in doing something to hopefully prevent concussion and definitely improve management of concussion and return to play. And they're putting research dollars into concussion.
Into basic science?
Now they are. Into concussion basic science. However, without going into any kind of nasty stuff, the thing I have with the NFL is that they're doing this great stuff when it comes to concussion because that's something that they can indeed control and do something about. But I think when it comes to CTE and the very nature of the sport, that's something that's probably very scary for the NFL because to remove repetitive hits to the head is something probably not on their agenda.
well, it becomes an existential issue for them.
Well, yeah, I mean, the liability of the NFL, NCAA, Pop Warner, all these entities have potential liability. So it's not exactly in their interest to support this.
Told you I'd save the best for last. I want to thank our panelists for imparting their knowledge to us, and as I think you've heard, we have still a lot of unanswered questions, and that is why we need your support, whether it's through CaringKind, hopefully, through the NFL, through whatever mechanism you would like to help us elucidate some of these issues in terms of traumatic brain injury, CTE, Alzheimer's, and so forth. And to wrap up our evening, I'd like to introduce or reintroduce Jed Levine, who will come up and tell us.
Thank you, Max. And I want to actually, once again, done a really masterful job of handling a very complicated clinical and policy issue and helping us understand it. And our panelists who did this with great passion and thoughtfulness on the subject that is, this is so new, relatively so new, and we are hearing really current, groundbreaking information tonight. So thank you for bringing this to us in a way that made it clear and understandable for us. So thank you so much, gentlemen. I want to recognize somebody in the audience, Dr. Mary Sano, who is the director of the Alzheimer's Disease Research Center at Mount Sinai, who is a co-author with Sam on the recent paper and has been very involved in many areas for many years in Alzheimer's disease and dementia and in concussion and CTE. So it's an honor to have you with us, Dr. Sano. So, it's great to hear good news that we now have a way to identify CTE in the living brain. Because unfortunately, when we talk about research, the pace of research and the findings have been disappointingly slow over the past couple of decades. And, but I think there still is reason for hope. And I was just at a meeting where I heard that I believe that 15 trials will be coming to fruition. We'll be able to share their data hopefully in the next 2 to 3 years and hopefully some positive results. So I think there is reason to hope. But until then, we need to keep informing our elected officials in Washington and in Albany and in City Hall to make sure that Alzheimer's and dementia remain a priority for our government. I'm pleased to report that as CaringKind, both research and advocacy are still integral to the mission and the work that we do. And we're proud of our research alliance with the Cure Alzheimer's Fund, and I know that Dr. Gandy is a member of that research consortium. And we're also proud members of the LEAD Coalition, which is Leaders Engaged on Alzheimer's Disease, which is a leading advocacy group, and we're joining 85 plus other organizations working collaboratively to focus the nation's attention on Alzheimer's disease and related disorders, on detection and diagnosis, research leading to prevention, effective treatment, and eventual cure, and to accelerate transformational progress in care and support to enrich quality of life. So look for news, hopefully over the summer or maybe in the spring, of a national summit on caregiving to be held next for the fall, the first time there will be a national summit on caregiving in Washington, D.C. And I think that's really exciting because it shows that caregiving is finally getting the attention that it deserves and becoming a prominent issue. We're also delighted to be a member of Us Against Alzheimer's, a grassroots organization committed to ending Alzheimer's by 2020. Us Against Alzheimer's presses for greater urgency from government, industry, and the scientific community in the quest for an Alzheimer's and dementia cure. I like to think of us Against Alzheimer's as a mobilization of forces. There's a Women Against Alzheimer's, Latinos Against Alzheimer's, African Americans Against Alzheimer's, researchers against Alzheimer's, and clergy against Alzheimer's, all working together towards this ambitious goal. And a group of advocates and I just returned from a national summit, which was convened by Us Against Alzheimer's, where former First Lady Laura Bush was honored at the national dinner, and she and all the former First Ladies spoke, some on tape, and Michelle Obama, about their embracing the cause with passion and commitment. So please join them and us by adding your voice to become an advocate with Us Against Alzheimer's, our partners. And there are sign-up forms on our CaringKind table. So please take a look at that and please sign up tonight. We need to keep the pressure on for both care and cure. So at town hall meetings, community events, wherever you run into your elected officials, your legislators, let them know that this is an important issue and ask them, what are they doing about Alzheimer's and dementia? It's important. So thank you, Sam and Bob. Thank you, Max. Thank you, Sam and Bob, for your lifetime of work in this field. So on behalf of all of us, for our affected relatives, for ourselves and our children who need to believe that there will be a day when Alzheimer's and dementia is just a memory, as I say every year, could you please hurry it up just a little bit? And remember, until there is an effective treatment, prevention, or cure, good care is the best treatment for persons with dementia and their families. So please stop by our CaringKind table and learn more about our free programs and services that in the meantime can help you cope with the challenges of caring for a relative with dementia. I also want to remind you to please fill out the survey that was handed to you and give it back to one of the ushers or leave it at our table. And before we end, I want to acknowledge once again Chrissy Vicendes and Carol, who have worked really hard on this event and making it the success that it was, and to thank Jane and Bill Brachfeld for their continuing support. And I'm pleased to invite you to please join us in the galley for a reception where you'll be able to meet our speakers. Thank you. We hope to see you next year. And if I could ask Llewellyn and John Latham to join us on stage, please.
The way you sip your tea.